Also, it will be posted on the Kentucky SOS website. You can always view this webinar and any webinar, past educational event on the Kentucky SOS website, which is spelloutkentuckysos.com. Today we will get started. I am delighted to introduce to you today's webinar presenters, Dr. Teresa Keller and Dr. Mike Kalfas, both from St. Elizabeth Healthcare, have a long resume of work with addiction medicine, and they are delighted today to join and to share with you and educate you on their work at St. Elizabeth Healthcare at the Journey Recovery Center in Crestview Hills. Both Drs. Teresa Keller and Dr. Mike Kalfas are on the Kentucky SOS Advisory Committee, and we are delighted that they are here today to present this webinar to you. Kentucky SOS welcomes Dr. Teresa Keller and Dr. Mike Kalfas.
Hi, good afternoon, everybody, or good morning, I guess it still is. This is Mike Kalfas here. I'm going to go ahead and start. We can advance the slides a little bit to the objectives. Are you on? No. So, okay, so we'll just assume that they've got it. Yep. All right. So the objectives for today, we want to talk a little bit about the impact of opioid use on the brain, rationale, benefits of treatment, assessment of opioid use disorder, treatment pathways and options, and what St. Elizabeth and Northern Kentucky have done in leading up to Journey Recovery, our organization, what's been done, how things got started, et cetera. So if we can go to the next slide, please. Looking at brain chemistry, this is just a nice little picture that just shows that what opiates do in the brain and in the nervous system. They can change the brain stem, an area that controls automatic body functions and depressed breathing. Obviously, that's the mechanism for an overdose. They can also change the limbic system. Limbic system, as I'm sure everyone's aware, is a subconscious part of the nervous system that deals with emotions, instincts, feelings, response to pleasure, etc. And it's really important to note that this is, to understand the disease, that we're dealing with the limbic system. So a lot of these things that our patients are going through are on a subconscious level. It's not just as easy as telling them, hey, knock it off. Of course, we use opiates for blocking pain messages transmitted by the spinal cord from the body. That's what we typically use them appropriately for, but the misuse typically infers what I just mentioned. Next slide, please. Opiates, what they do is they tend to bind to endorphin receptors. If you think of endorphin as, the neurochemical that you get when you get a runner's high. Endorphin functions in our bodies are to make us feel a sense of calm and peacefulness and that all's well in the universe sort of thing. In the thalamus, brain, and spinal cord, that can lead to analgesia, but in the limbic system, you may get those other desirable feelings and emotions from it, and often what leads us to becoming abused. So when in that limbic system, when we bind to receptors in the reward pathway, especially the ventral tegmental tract, there's a cluster of neurons called mesolimbic neurons in the ventral tegmental area. When those start to be stimulated repeatedly, it forms a reward circuitry where basically what happens is the opioid stimulates that, dopamine's released, and it becomes sort of a self-rewarding circuit that not only is pleasurable if it continues to be stimulated, it eventually becomes necessary to stimulate that to maintain function of the area. Next slide, please. And this is just a little graph of where, or little notation of where different opioid receptors lie in the central nervous system. You can kind of look at that. So a lot of the structures in the brain have receptors for opiates on them. Next slide, please. So when someone becomes dependent on opiates, they what you'll see is a development of tolerance, which is an upregulation in those receptors. That means you get more receptors than you had to begin with, and those receptors are unhappy if they're empty, which leads to withdrawal. So when those receptors get empty and they're not being filled, you start to get the symptoms of withdrawal. And there's a lot of different clinical tools you can use for that. We'll talk about those in a moment. It's thought that people that are IV users are going to have worse withdrawal scores, which is an important point. However, that dynamic is not as prevalent as it used to be. As we start getting stronger and stronger drugs that can be inhaled or snorted, such as fentanyl, some of our intranasal fentanyl users will have every bit as severe withdrawal as someone using IV. When withdrawal starts depends on the half-life of the drug. With heroin, it's going to start usually 4 to 6 hours after the last use. Methadone may start a day and a half, 2 days after the last use because of the time it takes for it to empty itself off of the receptors. Next slide, please. So what do people look like when they're in withdrawal? It's subjectively what the patient feels. Early on in my career, I had someone describe to me that opioid withdrawal felt like the worst case of the flu they'd ever had times 10. I guess more objectively, what we see are things like vital signs of tachycardia, hypertension, pupils dilate. Think of this as a sympathetic nervous system response. You're setting your sympathetic nervous system on fire, so things that would occur in a sympathetic nervous system, such as mydriasis, restlessness, irritability, you're sort of hypervigilant and having insomnia, you don't feel like eating, nausea, vomiting, diarrhea. You'll notice piloerection or goose flesh, where the hairs stand up and you get that goose-looking skin. Runny nose is prevalent, watery eyes. Those are all signs of withdrawal getting worse. Next slide, please. And the withdrawal timeline, like I said, is going to depend a little bit on the opiate that you're taking. Shorter acting opiates or things that are applied for quick use, such as IV or snorted drugs, they're going to pretty much start withdrawing about 6 to 12 hours after the last dose. About 30 or so hours, give or take, for longer acting opiates. If you're taking someone who's appropriately taking and swallowing an extended release oxycodone or oxymorphone, for example, or someone that's on methadone is going to take longer. The symptoms are generally going to peak around 72 hours, and those we've already talked about. There's going to be a lot of variability in that. Some people may not start for a couple of days and may have protracted withdrawal, especially if they're mixing drugs. They're mixing oxycodone and heroin and fentanyl and methamphetamine, and you're going to get an overlap of some of the withdrawal symptoms of that. But in general, it's going to peak around 3 days. Next slide, please. So, the symptoms and management of an overdose, based on the clinic, you're going to base that on the clinical picture, the history, and the lab test. There's certain things you're going to be more worried about. For example, hypertension, and a very egregious example would be, someone has a heart valve issue because of their IV use. You're going to worry more about those cardiovascular complications. But the clinical picture of what you see is going to have, if they have an altered level of consciousness, they may be on other drugs. You may see in an overdose, you're going to see respiratory depression. You're going to see meiosis. You're going to see evidence of drug use, possibly needle track. You might see pulmonary edema. Another thing we'll get to that. I was going to say something, but I think it's best said later. You may actually see pulmonary edema due to the cardiovascular effects. You're going to see altered breathing, that sort of thing. The history, of course, is going to have opioid use in it. Often multiple family sources are going to be telling you about that they've overdosed before. They have friends, family, You're going to get information from all those hospital records. The lab tests that you want to order acutely, right off the bat, you're going to make sure you get. You want to make sure that you're really treating an overdose. This person comes in, they're obtunded, their vital signs are off. Usually what happens is you go into a respiratory depression, respiratory arrest, then a cardiac arrest. Obviously, other things can look like that: profound hypoglycemia, alcohol intoxication, which can lead to hypoglycemia, sepsis. It could be a diabetic that's in decay. Unfortunately, Dr. Keller and I probably see a preponderance of type 1 diabetics who have no fear of needles. They get into young adulthood, and unfortunately, they develop an IV drug problem. We'll see a lot of those. So that can be a compounding variable. Fluid and electrolyte abnormalities, especially if they've been withdrawing off and on. Someone who may have been withdrawal for a couple of days gets a hold of some drugs and uses them, and now they've overdosed. They may be hypokalemic because they were having diarrhea yesterday, and Lord knows what. So you want to follow the electrolytes pretty well, and of course, because it's pretty uncommon to see a severe drug-addicted person who doesn't have at least something else in their urine, and you want to know what you're dealing with. So obviously, your next slide, please. But when you're this is management of an overdose. If you're in that situation, if you're the person running the shots, follow your CPR, your ACLS guidelines. Obviously, you want to give Narcan as soon as possible. You want to give Narcan as soon as you can, or naloxone. You want to reverse those effects, but brain functions at a loss here. The longer somebody's down, the longer they're not breathing, more potential for brain damage and failure to revive this person. So the name of the game is to hit with Narcan as soon as possible. I've done several Narcan training sessions, and the first thing we always tell a person to do when they come across somebody, whether it's a loved one at home or whether you're just out in the community, if someone's overdosed, the very first thing you do is call 911. We want the squad to come. We want them on their way. And when they do arrive, that person does need to go to the hospital. They can't say, hey, I'm awake now, I'm fine, talk myself out of it. We need that to happen. You call 911, then you give the Narcan. It's usually an intranasal. If you're in the field, it's going to be an intranasal spray. You spray half in one side, half in the other, and you back off a little bit, because if you're lucky and the person wakes right up, they're going to wake up hard. Some of them, they'll even come up swinging, because like I said, withdrawal, you're forcing withdrawal. Withdrawal is going to be a sympathetic nervous system boost, so they're going to have their fight or flight. That's basically how you would manage that. And of course, do your CPR if they don't revive. After a few minutes, you may want to do a second dose of Narcan. I've seen people with a lot of fentanyl have to get Narcan up to 6 or 7 times that were eventually revived. Obviously, I've seen people that, or heard of people that were given more doses of Narcan and never didn't revive. But I think the most doses I've seen in someone who was actually successfully revived and returned to normal, it was the 6th dose that actually brought them around. So it can be kind of a harrowing time. Everybody's kind of rushing around doing stuff. Next slide, please. And this is going to kind of lead us into the next segue. But when you look at what opioids do, some of the bad effects, besides the risk of overdose, one of the other reasons why we just don't want people to, we don't want to be dealing with this problem for people, obviously, besides the psychological aspect and the psychosocial aspect. Physically, on the right side of this slide, you can see we've got brain abscesses, skin abscesses, infected collapsed veins, endocarditis, lung abscesses, infectious complications of their IVs, such as hepatitis A, B, HIV, and that's just to name a few. Things that you see on the effects on a daily basis, just, they're often, just as they're up in their daily routine, they're drowsy, confused, problems with memory, fatigue, hallucinations, maybe even convulsions. When they're confused and hallucinating, they may look like a primary psychiatric disorder, and Sometimes these overlap and it's hard to tell. They need very thoroughly evaluated by both a physician in the physical medicine side of things and a psychological and psychiatric eval at some point, because these things do overlap. You can see things that, changes in the blood vessels in the brain, which can not be good, obviously. You could do a cerebrovascular disease from that, just from the use. They may not be breathing very well. Pupils are generally constricted when they're using, the opposite of when they're in withdrawal, when they're wide open and that sympathetic discharge. Oftentimes they're slurring their speech. They may be doing what we call nodding out, where they're just kind of struggling to maintain consciousness. They're almost always going to have some degree of sexual dysfunction early in their addiction. Their sexual activity may be tied to that, but as their drug use and their dependency escalates, things just stop working, and they're not able to achieve that. That's both. There's a lot of physical reasons for that. There's also hormonal consequences. Estrogen levels and testosterone levels may drop. One of the things we do in our screening test is we always, when someone comes into our practice, we check testosterone levels. And even in young, seemingly healthy men, you're going to see some very low testosterone levels, just for the opioid use and the stimulation of the liver has both caused increased metabolism of their sex hormones, as well as suppression of them. Some of those, if you remember a couple of slides back, there was of the places where there's opioid receptors, the pituitary gland is rich in opioid receptors, and it has they have a suppressant effect on endogenous gonadotropic hormones. So you're going to see a problem there. And then next page, or next slide, if you would. I'm going to turn some of this over to Dr. Keller. She's going to take over for a few minutes.
Okay, so I think Dr. Kopp has kind of hit on some of my things, but that's okay. So reiteration is always good. A lot of times with medical complications, I'll break them down into subsets of infections, such as HIV, hepatitis B and C, syphilis due to risky sexual behavior, and then of course the individual types of infections that are body parts that can be affected. Really anything, anywhere the blood flows, you can get an infection. So we've seen infected joints, heart valves, brain abscesses, toes. So and
vertebrae.
Then vertebrae, yeah. And then there's also local tissue damage just from injecting itself. One of the other things, too, that we see a lot of with our patients is neonatal abstinence syndrome, now called neonatal opioid withdrawal syndrome, or NOWS. And we will talk a lot about that during the end of this conversation. The societal implications are huge. There's loss of jobs, loss of families, moms and dads losing their children, kids being raised by grandparents. There's significant legal problems. Patients end up in jail, they have felonies, then they can't vote, they can't participate in society, they can't get jobs or housing. A lot of our patients with felonies have difficulty finding apartments that will accept someone with a felony. They can't get benefits, so they can't get vouchers for housing, they can't get food stamps. So there's just a lot of complications and results of drug use. I have other things listed there. And then there's just a small thing about the cost, and it's wide-ranging, but to treat HIV, it ranges anywhere from $21,000 to $54,000 a year. A heart valve replacement can range anywhere from $80,000 to $200,000. And then, of course, hepatitis C treatment has actually gotten a little less expensive than it had been. It used to be around $120,000, and now we're down to, depending on the type of medication, anywhere from $39,000 to $94,000. And then to treat a baby with NOWS, neonatal opioid withdrawal, can range about $22,000. So now I'm going to go to the next slide, which is screening for opioid use disorder. And this is SBIRT, S-B-I-R-T, which refers to screening, brief intervention, and referral to treatment. And this is an evidence-based approach to identifying patients with substance use disorder and those at risk for substance use disorders. This is, it was actually initially developed as a primary care or outpatient tool to assess for alcohol use disorder. And then it was extrapolated without any evidence to screen for substance use disorder and opioid use disorder in both the primary care setting and the emergency department. In 2008, the United States Preventative Services Task Force, or USPSTF, concluded that there was insufficient evidence for the use of SBIRT. However, in June of this year, they changed their recommendation to a B recommendation for use in adults 18 and over. So this means that SBIRT should be implemented when there are services available for accurate diagnosis, effective treatment, and appropriate care for the patient. However, it is still inconclusive for use in adolescents. The goal is to reduce health-related consequences, disease, and accidents, and it looks for early intervention, basically. And you use motivational interviewing during this process. But it's of prime importance that if you don't have resources available, it is not, or available to you either on site or that can be referred to, it is not recommended that you do SBIRT. I'm going to have you go to the next slide, please.
We should be on the one, yeah, one that says assessment. Good.
This is the one that says assessment. So there's a bunch of common screens that can be used for assessing patients with opioid use disorder. Probably the single easiest one is a single question screening. And this one asks, how many times in the past year have you used an illegal drug or used a prescription medicine for non-medical reasons? And if the answer is one or more, this is considered a positive screen and requires further evaluation. And the information I got on this is that it's 100% sensitive and 73.5% specific for detection of drug use disorders. And then there's a whole bunch of other things. I have audit listed because we use it here, but that's actually for alcohol use disorders, so I'm not going to go any further on that. The DAST is the drug abuse screening test, which is on the next page, so don't go yet. CRAFT is for adolescents, and I do have that listed for you all to look at as well. There's a couple different CRAFT screening interviews. Some are more difficult than others because some have added in nicotine and vaping. But basically, the CRAFT part refers to the areas that they assess. Have you ever ridden in a car with someone who's using? Do you use to relax? Do you ever use or drink or use drugs alone? Do you use to forget? Do you have friends that are worried, friends or family that are worried about you? And have you ever gotten in trouble? And so those are the things that are on the CRAFT screening test. The ASSIST looks for problems with alcohol, smoking, substance involvement, and then screening tests. And actually, it looks at 9 different substances, and it's quite complicated. I don't know that this is something that you would use in a primary care setting. And then likewise, the POSIT test apparently has 139 questions, so it's kind of involved and probably wouldn't be used in a really brief visit in the outpatient setting. The CAGE, any family doctor would know this one. It can be used for alcohol and opioids or other drugs. And basically it looks, have you ever tried to cut down? Have you ever been annoyed by people talking about your drug or alcohol use? Have you ever felt guilty about your drug or alcohol use? And have you ever required or needed to take a drink or use drugs in the morning to feel better? And then if we can go to the next slide, this is the DAST-10. This is what we use in our office. And patients can fill it out on their own, or they can have the physician or the staff can help them with it. You have to be careful too when you're giving people self-administered tests, especially in this population. One of the side effects of chronic opioid use is lack of education. So a lot of people start at a young age, and so they may not have the ability to fill these out on their own. So be aware of that. And then the DAST also comes in a DAST-20, which we don't use. That's too many numbers for us. And then there I have the CRAFT screening interview so that you can look at that. And then you can always go online and get the more involved one as well. And then we're going to move on to the next slide, which is treatment options and pathways. So when St. Elizabeth first developed our treatment program, we partnered with Hazel and Betty Ford and to present the 12-step facilitated model of treatment, or the Core 12, which is the comprehensive opioid response using medication and 12-step facilitated treatment. And they have basically 3 pathways of treatment. The first is no medication or therapy only. The second one utilizes agonist medication with therapy. And then the third is antagonist medication with therapy. And it's a really pretty slide, so I just want to look at that for a second. Okay, and next slide. Am I doing this one? Okay, so the first pathway, again, is no long-term medication. So we do use short-term medications for withdrawal, basically. What we have found is that in the outpatient setting, it is difficult to have patients be successful with this unless they have a really good support system, a family that's going to lock them in the basement and give them short-term medication. I don't recommend locking people in the basement, though. Typically, patients, if they want to go this pathway, will go to detox, and they'll probably the best type of detox would be someplace that offers medicated detox. There's a high rate of patients leaving treatment if they go to a detox without medication. Another type of treatment that will occur with the first pathway is patients may do residential treatment. And this is, with Hazelden and Betty Ford, this is pretty much their mainstay. They have residential treatment that then goes into outpatient. Residential treatment typically lasts anywhere from 30 to 90 days, sometimes longer. It's especially useful for patients who are unstable, who lack housing, or patients who have failed outpatient treatment. Intensive outpatient treatment is referred to outpatient treatment that has at least 9 hours of contact a week. So usually programs will have 3 days a week, 3-hour sessions, and they're basically group therapy where they have didactic learning and then also interaction with each other. This is often the first treatment the patient will have to lay the groundwork for their recovery, but it may also follow residential treatment. And then outpatient therapy is anything under 9 hours a week. And at Journey Recovery Center, we typically have 1 to 2 hour groups that patients attend, either at the beginning of their treatment, depending on their ACM criteria level, which looks at how severe their disease is, or they'll start with IOP and then move on to outpatient treatment, or the outpatient level of treatment. Sober living, many patients elect to live in sober living situations for additional recovery support. Often they will transfer there after they've done residential treatment. It is not for patients who are in active use. Unfortunately, oftentimes that also occurs too. The therapeutic techniques that are used include cognitive behavioral therapy, motivational enhancement therapy, contingency management, and then 12-step facilitated therapy. Cognitive behavioral therapy basically teaches patients in treatment to recognize and stop negative patterns of thinking and behavior. So it might help a person be aware of their stressors, their situations, and their feelings that lead to their substance use so that they can avoid them or act differently when it occurs. Motivational enhancement therapy helps people build motivation and commit to specific plans to engage in treatment and to seek recovery. It also is used to assess the patient's readiness for change. Contingency management is kind of like paying patients to do the right thing. So you provide incentives to reinforce positive behaviors, such as maintaining abstinence. And then 12-step facilitated therapy helps patients engage in 12-step programming and help guide them through the 12 steps of recovery. It's sometimes referred to as CBT with God or a higher power. Next slide, please. And so the medications that we use for medically supervised opioid withdrawal would be primarily buprenorphine, especially in the detox setting. And then you can also use basically symptom control. So clonidine can help with the agitation and irritability and sweats. There is some evidence for a combination of clonidine and naltrexone at a low dose. I've not used that personally. I don't know if Dr. Kalpas has, but it's in the literature. Amantadine used to be used fairly regularly with opioid withdrawal, but it is not.
It tends to be more with stimulant withdrawal. Yeah. It means where they use it for the tremors and stimulant patients, but yeah.
And then baclofen we use for the muscle aches and cramps and restless legs. Zofran for the nausea, trazodone for sleep disorder. Steroids also can be used to help with the irritation, more so the fatigue and muscle aches. And then Gabapentin is also used in the short term, but we have really kind of gone away from that due to the increasing
risk of abuse.
And it's sold on the streets, and it's probably one of the highest abused new drugs out there. And then dicyclomine we use often for the GI side effects, and then basic symptom relief we talk about, acetaminophen if you have a headache, ibuprofen if you have Tylenol, and the others to help with your GI side effects.
But you have to be careful with Tylenol a little bit because of their livers. I mean, a lot of these folks are going to have a significant amount of liver dysfunction, so you got to be careful with the Tylenol.
And so whenever we give these, we also give instructions on the dosing, and we check their labs. And I'm not a big fan of using multiple different things. So if somebody wants to take Tylenol PM, I tell them no, I wouldn't do that because you're also taking Tylenol on top of it. So you have to be careful. The second pathway, and I think we were going to kind of bounce this off each other. This would be utilizing agonist therapy with medication-assisted treatment, utilizing methadone and buprenorphine. Which one do you want?
I was just going to say, getting into this, I can't stress enough, what I say to patients when we get to, when we're going to use medication-assisted therapy, that's either an agonist or a partial agonist, that does not get rid of the need to do the things in the first pathway. The counseling has to be the therapy, everything else that Dr. Keller just went over with pretty good detail. That needs to occur still. And what I explain to patients, that's one thing our program is set on. A lot of places just give buprenorphine. We refuse to do that. We actually require therapy and medication carry an equal weight, if not more weighted towards the therapy. And my explanation to patients is this. I'll say, look, those receptors we talked about, those opiate receptors, I'll actually talk to them a little bit about them. I'll say those are like locks on a door. And when there's no key in the lock is empty, your brain gets angry. So what happens is every time you put a drug in, that's a key that goes into the lock, opens the door, and things start to happen. So the medication to stabilize your brain function is basically trying to fill those locks without getting you in trouble. So methadone is a key that opens the lock, but does it very slowly. There's an 8 to 12 hour lag time for when you take it, whereas buprenorphine is a key that goes in the lock and usually doesn't turn it. And I might say, if you ever had a key on your keychain that wasn't cut well, it goes in the lock very nicely, but then it doesn't turn the lock to open it. And that's kind of how you think of buprenorphine. It satisfies your lock, stabilizes your brain. But all that these medications do is they allow you to fix what you need to fix, or you're going to end up back where you started. So I think we kind of, if there's more specific questions about methadone and buprenorphine, we can get into those in the question time. But
you mentioned that in order to prescribe methadone, it has to be in an opioid treatment program, which is federally mandated and state licensed. It cannot be prescribed out of your office for opioid use disorder.
Right.
For buprenorphine, you have to be trained to dispense buprenorphine through the DATA 2000 waiver, which is an 8-hour course. And then there are limits on how many patients you can prescribe to, so you do have to keep track of that if you're going to do that.
So the way to look at that is putting it in a simple form. Under United States law, it is illegal to use an opiate medication or drug to treat opioid addiction. And then there are exceptions made to that law. Methadone is an exception, but for addiction, it has to be in a clinic. Clinics have federal guidelines, and the states may put additional guidelines on top of it. Kentucky is a state that has pretty strict guidelines. Other states may not have any state guidelines, and it just reverts to the federal. So if you see varying recommendations or regulations on methadone, that's why. If you're a pain medicine physician or even a primary care, you may use methadone, although we're kind of getting away from that now. Methadone can be an effective pain medication. Your records need to clearly document that you're using it for pain and not for addiction. You don't want any ambiguity in your record that makes it think you're treating an addiction problem in your office with methadone. Buprenorphine is intended for office-based opioids. So,
okay.
Then
the next slide. So basically, the pros for using methadone and buprenorphine are about the same. It reduces infections, reduces overdose, reduces crime, improves social functioning. Methadone has low abuse potential because it's given in an opioid treatment program where they have daily dosing. So there's very little diversion for that. For buprenorphine, it is felt to maybe be less stigma than methadone treatment, and there's potential effects on hyperalgesia. So oftentimes with opioids, you can have an hyperalgesic effect where the pain is not well controlled by the dose, so then you need to have more medicine and more medicine in order to control that pain. We don't see that with buprenorphine so much.
There have been some good studies to show that people that are chronically on methadone have a very decreased pain tolerance. You know, that things hurt that normally would, or they subjectively feel pain at a much greater degree than they normally would, and it's just because of the long-term biologic effects of methadone on the brain.
And we don't see that with Suboxone. Next slide, please. And then these are the cons, I guess you would say, against maintenance therapy with methadone and buprenorphine. Both of them can cause dependence because they're opiates. And there are problems with buprenorphine being sold on the street. So it can be addictive, and some people do abuse it. In addition, because of the way of the licensing, it is difficult to find doctors that are able to prescribe buprenorphine because of the additional training, and then the stigma that
which is why there's a big street value on it.
Yeah.
In a lot of cases.
And then you have to be careful if you give buprenorphine too early after detox, it can actually put them into a precipitated withdrawal. And then as far as the methadone, it can be pretty costly because it's a daily fee that you have to pay. And this site, as most OTPs do not accept Medicaid. Kentucky did change that recently, so they do cover Medicaid, but it's not free. Is that?
There's usually some kind of copay that goes along with it. So yeah, one benefit of buprenorphine over methadone is that it's extremely difficult to get an overdose death on buprenorphine, whereas with methadone, obviously, it's a pure agonist. If you keep cranking the dose up, you can overdose them. Whereas buprenorphine, actually, it's often quoted that there's no buprenorphine overdose death. It's usually buprenorphine with other things on board, especially benzodiazepines. They're very dangerous when you use them together, but buprenorphine by itself is pretty safe. It's from an overdose potential anyway.
And next slide, please. So the third pathway is with antagonist therapy with naltrexone. Naltrexone is an opioid antagonist. It decreases the desire to use opiates. In order to start naltrexone, which can be given either orally or injectably, or injectable, you have to be opioid-free at least 7 to 10 days in order to start it. And it depends on what opioid the patient is taking. So for shorter-acting opioids such as heroin or oxycodone, they might need to wait 7 to 10 days. For something that's longer-acting like Suboxone or methadone, they might need to wait 10 to 14 days or longer. Otherwise, it can put them into withdrawal. And it's a pretty significant precipitated withdrawal. There's no special training that's needed to prescribe it. You just need to know how to do it. And so read that package insert. It's a very large volume, 4 cc's, and it's thick and viscous, and you have to be careful because it will clot. And I've had it happen several times where we were mid-injection and it clotted. So then you've got to kind of take the needle out, get a new one, and start over. I used to have it clot in the container, in the vial one time, which was really odd. Make sure that you check your urine drug screen before you give it to make sure that they haven't had a positive test. And then I generally, on the first dose, I'll give them a test dose of oral naltrexone. Naltrexone has been shown to reduce post-acute withdrawal syndrome. And in general, my patients tell me that it reduces cravings, it increases energy, and it enables them to think more clearly, that they have more clarity of thought.
One danger of using A couple of things I always warn people about with Vivitrol, or the injectable once-a-month preparation of naltrexone. Very good drug, but we have to be careful. Number one is they need to have some kind of sort of identification if they're ever in an accident, they're in the hospital. It could be a little tricky getting analgesia because I have to give larger amounts of an opiate to override the blockade. But then toward the end of the dose, as the dose is wearing off, the doses that you were giving are now potential for an overdose. If I'm making that clearer. So, if it's once it gets to about 3-4 weeks after the shot, the naltrexone is wearing off. If you keep giving those higher doses of opiates, say someone had a severe auto accident and they're in the hospital, you need to monitor them because they can, what they were tolerating a week ago may now be too much of a dose because the naltrexone is worn off.
And they've got empty receptors just waiting for the opioid.
And one thing is I've seen only once out of hundreds and hundreds of patients on this drug is sometimes they will attempt to escalate their use, overpower the injection, which is very difficult but not impossible to do. And the fear of that is if they take enough, they may actually precipitate an overdose. I've seen a couple of patients, not overdose, but trying to override the blockade. They got such high levels of opiate in their system. And both of those, we put them in like 90-day inpatient treatment programs because, they were in a very dangerous spot, obviously. So.
And then finally, there's been a long discussion about what's better, agonist therapy or antagonist therapy. And there was a head-to-head study in January of 2018 that was published in The Lancet. There was a 24-week open-label randomized controlled comparative effectiveness trial that had 570 patients, and they found two things. First, it was difficult to start patients on naltrexone because they had to go through withdrawal first. Once they got through that with the rest of the patients and the dropout, they found that the effectiveness, it was equally safe and effective to use either agonist therapy or antagonist therapy. But in order to use antagonist therapy, you have to get through the withdrawal.
Right. So now here, as we're wrapping things up, we're going to transition into what Northern Kentucky's done.
So let's get to slide number 27, I think.
Yes.
27?
Yes. That's exactly right. It says Northern Kentucky's collective response to the heroin epidemic. So going back to 2012, Dr. Keller was growing her wings in addiction. I think you were practicing across the river at that point. I was in Northern Kentucky doing family practice. Another family practitioner, one of our colleagues, a gentleman named Jeremy Engel, he started getting together with other people and realized that we had all these plates spinning and everybody was doing their own thing and no one was coming together. And Dr. Engel organized what was originally called the Heroin Impact Response Task Force. And it was just a group of had an amazing leadership team. We call on everybody to come to let's start meeting. And it just started with us meeting with law enforcement, local government, various mental health and substance abuse treatment strategies, different healthcare providers, public health folks joined in, different advocacy groups. There are several of the parents groups, people that have lost their children to this. They had a seat at the table. That was very important. They did a lot of the legwork, especially when it came to some of the legal things we needed to get done. Local businesses became involved. They had a stake in this. Like I said, almost all the stakeholders were involved. The media was invited. Terry DeMio at the Inquirer, who has won a Pulitzer Prize writing stories on our epidemic, she's one of our close contacts and relies on members of this committee still. The faith-based community was invited and showed up. The schools showed up. So initially, and at the time, I actually was not working for St. Elizabeth. I was working for the Christ Hospital doing family practice. But this wasn't a St. Elizabeth thing to start with. It was Northern Kentucky coming together and saying, this is the problem we have. Everybody who's got an idea of how do we fix it, bring it to the table so we can make solidified recommendations. HURT was a recommendations organization. The reason things kind of gravitate towards St. Elizabeth is because St. Elizabeth Healthcare, they were the biggest, where Dr. Keller and I both work now, the biggest, most dominating healthcare providing entity in Northern Kentucky. They are the ones that picked the gauntlet up and said, hey, look, we want to back you up. And they started hiring people to do different things, some of the people that were on HURT. And it wasn't necessarily to control. They were trying to help. It's just they were the only entity like that stepping up, none of the other entities really were, had much of an idea of what to do. And St. Elizabeth was the first one to say, look, where do you guys want us to go with this? What do you want us to do? So
we'll go to the next slide. And this is just a little bit about St. Elizabeth Healthcare. They've been around for about 150 years, or more than. It's sponsored by the Diocese of Covington, and it started with a small hospital in 1861, and we now have 5 facilities in northern Kentucky. We have a combined total of 1,047 beds, and we have St. Elizabeth Healthcare also includes St. Elizabeth Physicians, which is a multi-specialty physician organization with over 390 physicians, 180 nurse practitioners or advanced practice providers, and then 1,300 non-provider associates. And our area extends to northern Kentucky, southwest Ohio, and southeast Indiana. Next slide. So we have a population we cover a population of about 460,835 people in northern Kentucky, and we comprise 10.3% of Kentucky's total population. And it's estimated that in northern Kentucky, about 29,493 people are misusing opioids.
I was asked early on, how many people do you think are doing this? By people like Terry DeVia, the reporter I mentioned earlier, and when I would say 10,000, 20,000 people, they laughed at me. This was 15, 20 years ago. I'm like, no, we really do have that many people, and we're actually starting to validate that with some information. So,
and we'll go to the next slide. And so basically, the destruction caused by opioids in our area has been tremendous. If we look at babies that have been exposed to opioids, it's about over 1,000, and then 428 thus far, actually as of 2019, were now babies, so babies who suffered from neonatal opioid withdrawal syndrome. We've had 1,445 deaths as of 2018. I don't have anything after that.
And that's just from 2012.
Yeah, so that's in 6 years. With 8,562 deaths between 2012 to 2018, and then over 10,000 overdoses between 2011 and 2019. And really, this is why SAMES stepped up. When the community started getting together, SAMES decided, one, that there was pressure, but two, they have a commitment to their patient population and to their community. And, Dr. Kalfas and I have both worked for different healthcare systems in this area, and I haven't seen any response from any of the other health programs that SAMES has had. It's really been inspiring. This slide really just kind of goes over what Dr. Kalfas already talked about. It looked at the collective plan with the community and then SAMES' role, and you see all these things that are checked off, that we're checking off everything that we can and trying to help out. The one thing that's not checked off is Sun Behavioral Hospital, because this is an older slide, and actually Sun is open and has been open for 2 years. And so the speed with which SAMES and the community moved with this has been incredible. And this is kind of the timeline that we see. In 2012, they started using data to determine that there was a problem. In 2015, Baby Steps was created, and that is a coalition between St. Elizabeth Healthcare, which provides nurse case managers and peer support specialists, and in conjunction with St. Elizabeth Physicians, where we provide the mental health counselors and the physicians to treat patients. And also in 2015, we distributed Narcan or naloxone to first responders, to the hospitals. And then it doesn't list this here, but SAMES actually opened the Addiction Medicine and Recovery Center, which is now Journey Recovery Center, in 2015. And when we opened our doors, we had 3 staff. We had 3 people working there. It was myself, I had a nurse, Stephanie, and a medical assistant, and 200 patients on a waiting list. And now today, we'll go on to that later. We've got lots more people here today. In 2017, we transitioned the Addiction Medicine and Recovery Center over to a larger location and renamed it. I tried to have them use my name, but they weren't on that.
We'll name it after you posthumously.
And to date, we've served 3,814 patients with over 78,000 patient visits. In 2018, we started the Bridge program in the emergency department, through core grant funding. With that, we were able to refer 93% of patients that were seen to treatment, and it serves as a basis for system-wide referral. And then in 2019, Journey Recovery Center started providing opioid use disorder and substance use disorder treatment in the hospital over at the San Elizabeth Fort Thomas location. And of those patients that we see there, about 70% follow up for care. I'm going to have you go to the next slide.
While she's doing that, I just want to throw in one of the things Dr. Keller was integral in doing with Journey Recovery. It's a very important part of our program. Is not only do they have therapy, we have the groups here directly tied with the medical providers. I mean, I walk across the hall and talk to the therapist about patients so that we can coordinate their care. But she also has very thorough case managers and peer support. During this last, during the COVID epidemic, our peer support specialists were an integral part of keeping up with patients. There was a point where we had almost no contact at all, except for these peer support individuals calling our patients every day and saying, "How you doing? Let me check on you." And that's what keeps a lot of people in treatment, is these peer support who reach out and are extensions of us, really. So that's an integral part of the journey. So
we'll go to the next slide. Establish internal task force on addiction. That is running monthly.
No, I want my one.
Just and then next slide,
beginning.
what we're trying to do is to incorporate children in the hospital, the recovery center, and also support services through government planning, grant writing, community outreach, state policy, leadership. And then I have the next slide, which is number 35, looks at the core grant, and this helped us develop our emergency department bridge program funding. And if you look, started the core in 2017, we had distributed 80
healthcare and pathways
families and to the EMS and law enforcement as well. And then on the next slide, you see that with the establishment of Journey Recovery Center, with state funding through grants and then also through the San Elizabeth Foundation, as we built the JRC recovery program, we see that our overdoses started to decrease. Our baby steps program mentioned.
I'm going to walk over there later because they got I hear that. They probably won't tell me, but if they would see him, it'd be good. So.
Presentation mode is now enabled.
What's going on?
Go ahead, please, Dr. Keller and Kalfas. We had to mute all the lines. I apologize.
Okay.
Thank you.
So on slide 38, I have it's based on 2017 results of our Baby Steps program. Between 2015 and actually it was late 2015 and 2017, we had 68 postpartum referrals, 103 prenatal referrals, and we had helped take care of 170 pregnant and parenting women. If you look to the next slide, number 39, reduced number of babies born in withdrawal. Between 2017 and now, actually 2015 and now, we have served over 1,200 women. 98% of our moms are involved in Baby Steps are parenting their children. We have early induction onto medication, either in the office at Journey Recovery Center or for patients that are higher risk or greater than 24 weeks. They are now going to our buprenorphine induction program at the hospital. And then we have access to our peer support specialists. And the Baby Steps program with the nurse case managers and peer support is it's free. It doesn't we don't bill insurance other than for our medical and therapy services. And what we found is that with this, we've had a 36% decrease in babies born with neonatal opioid withdrawal syndrome between 2015 and 2019. And that's the next slide, number 40. And then I'm going to go to the next slide. This just refers to the buprenorphine induction program at the hospital. We first started doing buprenorphine induction in 2015 with lower risk pregnant moms, and then expanded that into the hospital in 2018. And then also our length of stay in the NICU is 50% less than the national average, which is pretty exciting. Next slide. This year, St. Elizabeth Physicians was honored to receive the 2020 AMGA Foundation Acclaim Award. And part of that reasoning, there were a lot of different things that I guess St. E's did to achieve this, but one of those things was our comprehensive opioid use and substance use disorder comprehensive treatment plan. And then next slide. I'm going to go to who we are. This is really just Journey Recovery Center because there's so many other people that are involved in this. We couldn't get all the pictures, but you can see that we have 5 full-time practitioners. 3 of us are board certified in addiction medicine, and we have 2 nurse practitioners. We have moonlighters from the community hospital that are private practice physicians who come in on their day off to help out because they're committed to treating this patient population, and it's been a really great experience having them here as well.
That group are internists, family docs, one's a retired GI physician.
Yeah.
I mean,
it's pretty amazing.
It's a big mixture of people helping out.
A gerontologist as well, yeah. And then next slide. This is our therapy team, and we have 8 therapists. Yeah, 8 therapists that are all licensed independently and provide services. We have clinical. We have LPCCs, licensed professional clinical counselors. We have LCSWs, LMFTs. We have kind of the whole range, and it's an amazing group of people. We also have targeted case management team, and then peer support specialists. And we didn't have all their pictures. So, and then not to forget, we have amazing patient service reps and medical assistants and LCNs who work with us. And then, so this is really our program in a nutshell. We do outpatient therapy and medication-assisted treatment. We provide IOP, or intensive outpatient programming, which is 9 hours or greater a week. We have morning, afternoon, and evening groups. We do medication-assisted treatment groups, which typically run anywhere from 9 to 12 months or longer. They are 60 to 90 minutes, and we have about 60-plus therapy groups that we run. Next slide. We do individual counseling and targeted case management, and this kind of gives you a list as to what we do there. The next slide. And then our peer support specialists are basically people who are in recovery who guide our patients and through their own experiences. They tell their story, they provide hope and accountability too. They will meet them at meetings. They most of them are available almost 24/7 by phone if needed. They assist with some of our groups, and they also have a caseload of their own. Our Baby Steps program, as I mentioned before, is a cooperation between St. Elizabeth Healthcare and St. Elizabeth Physicians, and we have 3 nurse case managers, 3 peer support specialists. We have 2 therapists, and then basically our entire medical team helps take care of the MAC.
It's all interwoven, which is the point.
Yeah, we help provide transportation, diapers, and we partner with area recovery centers. And then our partnerships include the Kenton County Detention Center. We're working on Campbell County and Boone County. We work with Life Learning Center, which helps patients become independent and get jobs and training and things like that. North Key is the local mental health provider, transitions. They have residential treatment outpatient services. And then Sun Behavioral Health is our inpatient unit. And then we've also partnered with Uber Health for transportation, and we've had several grants for that as well. So we are always looking for grant funding too. So if y'all know of anything, let us know. And then next slide, these are some of our initiatives. And one that's not on here because it's pretty brand new is our Workforce Initiative grant. And we just hired a case manager and a coordinator and an overall coordinator for that program, and that's Dr. Bonnie Hedrick, who actually provided a number of these slides for me that detail St. Elizabeth, and so I thank her for that, along with Jordan.
Dr. Hedrick was one of the Hurt County members with back when the task force started. She was one of the members, and you brought her on full time.
Yeah, and I also want to thank Jordan Brown for some of his slides as well. But these are some of the programs that we do and the initiatives that we do as well. We do provide cases law assessments. We provide Kentucky Board of Nursing assessments, and we're in a contingency management pilot through RealWorks, and we're working on expanding our service locations. And I think that's about it.
Yep. Sorry, so we ran a little longer than we wanted to, guys. I hope this was helpful to everybody.
And that we didn't talk too fast.
Right. We'll stick around for some questions, but if people need to go, we realize that. I think our emails were attached to this at some point. If not, we can get those out. But if there's any specific questions that you have to go and you want to ask, you can ask me an email.
Unfortunately, we can't get the chat box on here, I think.
Okay.
Presentation mode is now disabled.
Thank you so much, Dr. Keller and Dr. Kalfas. This is Emily Henderson with KHA, and I can help monitor the chat box. The lines are now open. If any of the participants on today's webinar would like to ask a question over the phone, please do so or type it in the chat box. Dr. Katie Marks says that there are 3 funding opportunities posted right now that close in November. CORE has 3 funding opportunities, and she has the website listed that could be used for St. Elizabeth and other facilities across the state. I know I shared that also. Please, everyone, take advantage of that. Thank you, Dr. Marks, for posting that in the chat box. Also, while you were thinking of questions, I will list on the screen the continuing education access code. Please note the date and time that the portal closes. This is continuing education for medicine, pharmacy, and nursing. I will have that on the screen. I will also email this out to all the participants. I will also put in the chat box both Dr. Keller and Dr. Kalfas' email. Give me just a moment to type that in. Also, I will put that in an email to all the participants too. Kentucky SOS is also proud to offer House Bill 1 CE for our providers. That ID number is on your screen at this time. Are there any questions for Dr. Keller and Dr. Kalfas at this time?
Please feel free to reach out to us about anything, if, you know, at a later time if you want to.
Okay.
Hello.
Yes.
This is Dr. Pat Withrow from Paducah, Kentucky. Teresa Culver gave me a call this morning and told me that you were going to have a webinar today, and I am very impressed with all of the activities and the help that you're giving your community up there. I've been there a time or two and met with Teresa on different things, but I'm so proud of what you guys are doing. You're way ahead of a whole lot of institutions in the state for that.
Thank you, Dr. Withrow.
Thank you so much.
Yes, Kentucky SOS is so delighted to have Dr. Keller and Kalfas and their experience in addiction medicine on the advisory committee and to offer today's webinar. I have posted their email addresses in the chat box. I will also email that out. If anyone has questions, feel free to always, you can contact me, Emily Henderson, at ehenderson@kyha.com. Dr. Keller and Kalfas will also present the 3rd webinar in our 4-part behavioral health webinar series on November 16th, which is a Monday from 12 noon to 1 p.m. Eastern Time. You will not want to miss it. That is on legal topics, including Casey's Law, education regarding the X waiver, House Bill 1, and House Bill 333. If there are no questions for the presenters at this time, over the phone lines, we'll leave them open just for a moment, and the chat box. We will close today's webinar. We'll give just a moment. Thank you for everyone attending.
Thank you for having us.
Thank you so much for sharing the great work that St. Elizabeth Healthcare. Okay.